Hi, I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. We're going to be talking about neurosurgery and what's new in neurosurgery. I have a wonderful guest here, Dr. Douglas Cohen, neurosurgeon at Richmond University Medical Center, someone I've known for a long time, someone we've trained at similar places at Columbia many years ago. And I want to say thank you and welcome to our show. And I'm sure you're going to enlighten us with your model and all the things about neurosurgery that's new. So thank you for coming.
Thank you for the opportunity to come here and talk to your audience.
Thank you again. So we're going to talk about neurosurgery. And neurosurgery has this aura, this concern. You think about, as a practicing neurologist, one of the reasons I became a neurologist, I sort of felt that your soul and your essence was in your brain. And I look at people's brains in certain ways by asking questions, doing certain diagnostic tests. You actually get into people's brains. So are you cutting out anything there that's really important? And people are always worried about the deficits that could occur with it. So as a neurosurgeon, how do you get to be a neurosurgeon, and what training do neurosurgeons have?
Well, neurosurgery classically is one of the longest training periods, and with good reason. Neurosurgery involves significant technical skills and abilities, and it just simply takes time. So after you graduate from college, after you graduate from medical school, which is an additional 4 years, the neurosurgical training can be anywhere between around 6 and 7 years, and sometimes even longer, depending upon fellowships. So people from the outside think, oh my God, how could you do that? Or why would you do that for so long? And it's because, A, you really need to. In order to do a good job to help your patients, you really need that technical savvy. And secondly, as you train, you are doing what you love. And so it's not necessarily a burden as if you are waiting for the pot of gold at the end of the rainbow. You're on your journey and you're doing that work. And simply put, it's in the patient's best interest that it remains such a long-term and technical training period.
So I'll ask you a question which, in a way that I think you've already given us the answer. Why did you become a neurosurgeon?
It's interesting. When I went into medical school, as an undergraduate, I had a double major in biology and psychology, and I too was just interested in the brain. I thought that actually I wanted to go into psychiatry initially, because to me that was that kind of mind-brain continuum. However, for a variety of different reasons, as I went to medical school and saw what it's like to be a psychiatrist, I just realized that that wasn't for me, that wasn't where I was going to flourish. I wasn't going to be happy myself, nor was I going to be the best doctor that I could be. And so as I kind of made my way around the different subspecialties, I found neurosurgery to slake my interest in the brain and also to help people in a real substantive fashion.
And you are, and hopefully I am, and it's something very wonderful. So the brain is in that head. So tell us a little bit about the model that you've brought, and we're going to talk about different neurological and neurosurgical conditions. That there are certain things that I take care of, and if somebody comes in with a headache or back pain with the spine, which we're not going to be talking about too much today, but there are a number of neurological conditions that I see, and then eventually you see, that we have to make a decision whether there's a neurosurgical component or something that we could do to make someone better. So tell us a little bit about the model that you've brought in and maybe orient everyone, the front and the back. I think we sort of could tell the teeth and the nose.
Right. I mean, this actually, unfortunately, is not a model of the brain. It's a model of the skull in which the brain sits. The brain essentially is in there. But it gives you a pretty good idea of where the brain is and also how we get to it. We have to go through what is a very kind of hard outer shell. And, evolutionarily, there's very good reason for that hard shell to be there. The brain, in reality, if I can get a little graphic, has about the substance of tofu. It's very soft, and even the slightest little tap to it, if it were exposed, would cause potential injury and damage. So that needs to sit in a very hard container, the skull. And much of what we do, and most of what we treat in neurosurgery in the brain involves having to go through the skull first. And sometimes that can be part of the nuance and part of the difficulty. We have to use very strong and powerful tools, drills, saws, to get through this with the understanding that literally millimeters away from us, an eighth of an inch or a quarter of an inch from these powerful tools, from this drill, is this incredibly soft and incredibly important organ that has to be protected during all phases of the procedure.
So let's start with head trauma. You were mentioning it. So a lot of people fall, a lot of people hit their heads, younger people, sad to say older people, which really can cause a major issue. People on blood thinners, people not on blood thinners. So when someone hits their head, what do they do? Do you go to the neurosurgeon first? Do you go to a neurologist first? Do you go to the emergency room? How do you define a little bit about head trauma and where we go with that?
There's no really simple way to answer that question. The reality is people hit their head millions of times a day, and the overwhelming majority of that require nothing other than maybe some ice, or sometimes not even that. It really depends upon what kind of problems that person has. Obviously, if there's any issue with consciousness, if the person is unconscious, that person needs to seek medical attention. Not in a neurologist's office, not even in a neurosurgeon's office, in an emergency room, where they can get quick care that may in fact just be observation for a couple of hours as the person emerges, and they can potentially go home. The more difficult circumstances are the people that hit their head and develop a little bit of a headache. Does everybody who has just a little bit of a headache require medical care, or does everybody not require medical care? The answer to that question is neither. Sometimes somebody with even a minor headache actually does require medical care, and sometimes even neurosurgical care. But in general, if headaches are mild, if there's no associated nausea or vomiting, if there's no change in consciousness, if there's no double vision or weakness or numbness or tingling associated with it, then generally those kind of problems are self-limited. What we've learned now, especially as many of these studies came out relating to the professional football leagues, even, I wouldn't call them minor traumas, but even traumas from which we can recover very quickly can still have long-term effects. The problem is there's not much that we can do to treat those traumatic insults other than to avoid a double exposure, to avoid further trauma. So the surgeon more gets involved when there's a real acute injury. In other words, something that's happening quickly and that something requires acute intervention for.
And we hear famous cases of famous people, maybe that's a better way to say it, who've had head trauma and then a few hours later succumb to it.
Right.
People in a hotel room, people skiing, and there are terms called epidural hematoma, subdural hematoma. Maybe if you can give us a little bit of an idea of what the issues are. And I think you said it so eloquently, that if patients come in with neurological symptoms, basically double vision, blurred vision, in addition to loss, and you don't necessarily have to have loss of consciousness.
Right.
But the idea that you have numbness on one side of your body, swallowing problems, speech problems, all the things that we think of with a stroke, because this is an acute event, really has to be taken very seriously. So maybe if you could tell us, that we've heard of people having what's called an epidural hematoma and then a subdural hematoma. And I know the model's not perfect for it, but tell me what a neurosurgeon's role is, and if someone comes to the emergency room, where we are with that.
Yeah, epidural hematomas, subdural hematomas, they are both the result of trauma. And anatomically, we know what the difference is between the two of those. But what the real critical issue here, and it's something I alluded to before, you have this soft structure in essentially this hard, rigid container. And there's not a lot of room for anything else to be in there. And so if a patient starts to develop bleeding, you mentioned before blood thinners, that puts patients at increased risk of potential bleeding in the head or intracranial bleeding following a relatively minor trauma. So I would like to say, despite what I said before, if you are on a blood thinner, if you're on Plavix or Coumadin, and you have a relatively minor head trauma, you may want to get that checked out, because those things, unfortunately, when you're on blood thinners, can really sneak up on you and can cause real problems. But going back to the initial explanation, the problem here is you have the soft brain, and then you have a new kind of mass within this rigid container. And that mass is a blood clot. And as the bleeding increases, that blood clot increases in size to the point where it's going to start to push on the brain. And at a critical juncture, that pushing is going to cause dysfunction. First it causes headache, then it causes nausea and vomiting, then it causes lethargy and loss of consciousness and weakness, and eventually coma and death.
So again, a very dangerous situation. And how do we diagnose it? We, of course, evaluate the patient, and imaging studies of the brain, like a CAT scan, are really crucial.
Right. This is one of the few places where a CAT scan is still the superior diagnostic modality. It is not better than MRIs. It is quicker than MRIs, and it is better for blood in the brain. So obviously, you've got to get yourself to medical attention. You've got to get to an emergency room. And if a CT scan shows a blood clot, sometimes even a CT scan that shows a blood clot, that shows a subdural and epidural, does not require surgery. If a patient is intact, if we can observe the patient, the body will actually take care of that blood. The problem is that process, that degradation of the blood clot, that takes days, weeks, and sometimes even months. And sometimes patients don't have that much time. If the blood clot is too big, if there really is compression of the brain, that's when we get involved. And again, going back to what we talked about, we have to drill a hole in this kind of hard, rigid container, and we have to remove the blood and remove the pressure from the brain. Even though that clearly is brain surgery, we are not actually operating on the brain. We are doing everything but operating on the brain. We're removing a portion of the skull, we're evacuating the hemorrhage, and then we are just allowing the brain to re-expand to its normal proportions.
Thank you. So that's important, just to talk about head trauma, especially when we're dealing with our audience. A lot of people hit their heads, kids hit their heads, and there's always that scary concept of what's going to happen. And as you mentioned, repeated head traumas really are additive, and especially people who are playing football. We see that with the chronic traumatic encephalopathy, where people go on to have dementia and very serious side effects with regard to head trauma. So let's go into a little bit of a non-emergent neurosurgery. And I see you have our model here, and we're going to talk about the idea about hydrocephalus. So a lot of people have water on the brain. We think about it as kids who have big heads and have hydrocephalus. But then in adults, especially people who've got some memory problems or bladder issues or walking problems, especially in my practice as a neurologist, I see a lot of people come in, older patients, who come in with any of those three complaints, and we almost always will get an imaging study to see. And a lot of times we see that the ventricles or the water-filled pouches of the brain are enlarged. How do I know whether to send someone to a neurosurgeon to see if they have hydrocephalus, and is there a treatment for it that's now available that may be helpful for these patients, and maybe reverse it or slow down the progression, or maybe just stop the progression of some of these very damaging problems, such as memory loss, bladder issues, walking problems, that could really lead to a lot of problems in any patient, especially someone who's a little bit older.
Yeah, I mean, you already kind of referred to classically what this is. It's basically called normal pressure hydrocephalus. Without getting too far into the pathology or pathophysiology, it's increasing water, increasing cerebrospinal fluid in the ventricular spaces, in the CSF spaces of the brain, and over time, and no one is actually quite certain why this causes the symptoms that it does. It causes walking difficulties, it causes difficulty controlling your bladder, and it causes memory difficulties.
Why do we have water in the brain?
You know, that's an excellent question too. A lot of people think it's a shock absorber. I think a famous neurosurgeon once called it brain urine, but a lot of people don't believe that anymore either. We don't know, but it's there and it can cause problems. But when it's not causing problems, it's obviously there for a reason. But in any case, we have now been able to treat these kind of problems, normal pressure hydrocephalus. It is one of the few causes of dementia, which is a type of dementia, is Alzheimer's disease. Alzheimer's disease is something separate, but they can both manifest as a person as they get older, who is unable to remember things, who starts to lose aspects of their personality, lose the ability to take care of themselves. This is one of those problems or disease processes that we can actually change and potentially reverse, unlike Alzheimer's disease, which, as you know, really essentially has no treatment or no cure at this point.
And the crucial aspect to that is if you're having memory issues, bladder problems with no clear explanation, or your walking is getting worse, it's important to seek medical attention, whether it's your internist, or it's going to a neurologist before you get to the neurosurgeon, to do some kind of a diagnostic workup in order to see, do they have this condition that we could treat?
Right.
And what we've seen is there's a percentage of patients, it might not be, it's not half the patients, but a significant number of people who've come in who have memory issues, their family brings them in, especially early on, and they realize they're just not right. And when we get an imaging study, predominantly an MRI now, because that really shows us a lot of the brain, and it's very good detail. And if they seem to have hydrocephalus, the idea of us having a treatment modality is really something revolutionary and can save their lives or give them a good quality of life. So tell us, what do you have, what kind of a device, and how do they treat it?
Well, the treatment for this is something called a shunt, and a shunt has actually been around for probably about 40 or 50 years by now. And what that essentially is, a shunt is something that gets fluid from one area to another. You can have shunts for problems with your kidneys. You can have shunts because of problems in your liver. But this is a particular type of shunt that essentially drains some of that extra fluid in the ventricles, and it actually drains it into the space around your abdomen, called the peritoneum. And there it can be absorbed normally and does not cause any problem. But placing that shunt is something that the neurosurgeon does. And one of the issues with the shunt that we had for 20 or 30 years is you had to set a particular pressure so that when that pressure was exceeded, that's when the fluid would drain. You didn't want that pressure to be too low. That would cause too much drainage of fluid, which could not only cause headaches, but it could actually cause the development of what's called a subdural, which we referred to before. That this would be an atraumatic subdural, but it could be something that could cause brain pressure. If you don't drain enough fluid, then the patient is not going to get the benefit of the shunt. There simply won't be enough cerebrospinal fluid going through the shunt, and the patient will remain asymptomatic as they were before. And the only way to change the setting of the pressure of these shunts was to actually remove a valve and replace it with another valve that was set at a different pressure. That required surgery. That required cutting down on the valve, dissecting it out of the scalp, and replacing it. Now what we have, and what's been available for probably about the last 10 or 15 years, but has become much more kind of generally available, is what are known as programmable shunts. And what that allows us to do, and I don't have a picture of the shunt, but I have a picture of kind of the device. What we can do is we can put this device on the patient's scalp. And this is a patient in the office. We can place it on their scalp, and with a dial, by telemetry, we can essentially change the pressure of the shunt and either increase the drainage or decrease the drainage as necessary. Every patient is different, and when you have that ability to actually change the pressure of the shunt without having to do the surgery, you can really fine-tune the shunting of normal pressure hydrocephalus, and you can really significantly impact and potentially improve your ability to treat those symptoms, the dementia, the incontinence, and the ataxia, the difficulty walking, without exposing the patient to any further surgical intervention.
Fascinating, and just important, just as a public education issue, that the idea to keep attuned to this, and not just to say, well, you know what, mom, grandma is sitting in the corner, their memory is poor, we're not going to do anything because there's nothing that we can do.
Right.
And there really is.
Right.
I'm going to go on to a new topic.
Okay.
Patients come to me all the time with headaches. And every patient I have who's ever had a headache is worried that they've got a cerebral aneurysm. There's a relative who had an aneurysm. They read about it in the newspaper. And it's my evaluation, of whether we get imaging studies or not, is really to see if they do have an aneurysm, to see whether we judge it or the odds are high or low. A lot of times when we get pictures, and again, rarely, maybe I'll say not a lot of times, we do find an aneurysm. And sometimes, sad to say, we find it when someone has already bled from the aneurysm, and that's a difficult case of someone who's had a hemorrhage. And I think some of the older literature says that half the people with cerebral aneurysms don't even make it to the hospital. The idea of someone, if we find an aneurysm on one of our diagnostic studies, whether it's for headaches, dizziness, whatever, and what my role in that is to find a neurosurgeon or a capable healthcare professional to treat the aneurysm. And our topic of today's talk is really new treatments in neurosurgery. And I think that's one of the, this is really, in all of medicine, one of the newest type of treatment changes that we've had over the last 25 to 30 years. How do we treat someone with a cerebral aneurysm? And since being an expert in the field, just give us a little idea of what you do if someone has an aneurysm, and how frightened should someone be if they've got a tiny aneurysm, and really try to take a very complicated, full grand rounds topic, which means things that we talk about for an hour to each other, and make it somewhat understandable, because it's such a scary thought.
Right. Well, an aneurysm is essentially a bulge or a blister in a blood vessel. And what's important to understand is that if that blister does not rupture, if it doesn't break, it will not cause headaches. So the only really circumstance where you will get headaches from an aneurysm is when that aneurysm ruptures. And those are classically what are called the worst headaches of somebody's life. And that's because we've all had headaches. And some of us are even unfortunate enough to have migraine headaches. And migraine headaches can be horrible. But an aneurysmal subarachnoid hemorrhage potentially can be even worse than that. It is an overwhelming headache. It is an overwhelming pain. And once those aneurysms rupture, as Allan alluded, there is a very, very high mortality rate. It may not be as high as 50%, but it's at least 35%, meaning if you have a ruptured aneurysm, you have a 1 in 3 chance of dying at some point. And that's because it's a very complicated issue. A whole bunch of things can happen. The patient can actually develop hydrocephalus for a different reason. They can develop something called vasospasm. There are many different potential complicating factors. And so what we try to do if we discover an aneurysm before it ruptures is to have that aneurysm treated. In other words, to have it occluded or closed off so that it cannot bleed, so that that blister cannot break. And unfortunately, your answer to me is, what does a neurosurgeon do? A neurosurgeon doesn't do anything for that anymore. A neurosurgeon sends it to what are known as interventional neuroradiologists. And the overwhelming majority of those pathologic entities, those aneurysms, those unruptured aneurysms, are treated through catheters that are threaded up through the blood vessel. And then those catheters allow the deployment of sometimes glue, sometimes coils that can fill up that little blister and cause it to essentially coagulate, to clot off so that it cannot rupture in the future.
So we don't do clipping much anymore?
Very, very rarely. Very, very rarely.
And that's been, for patients, the post-treatment recovery is much shorter because of
Much shorter, yeah. Which is not to minimize a cerebral angiogram. It's a significant procedure, but it's different than having your head cracked open.
Right. So that's a positive,
Yes.
of course. Let's talk about brain tumors. So we had the conversation that patients come into my office all the time with headaches and are worried that they've got an aneurysm. The other portion of the patients, or even the same people who are worried about aneurysms, are worried they have a brain tumor. And rarely we find brain tumors, but sometimes we do, and most times they're not the cause of the headaches, way less than 1% of patients. So how do you divide brain tumors up? A number of my patients have something called a meningioma or benign tumor. Maybe you can give me us a little bit of an idea where the neurosurgeon comes in. And I think the whole question is, do you take it out? Do you not take it out? Do you watch it? Do you get serial testing for it? And so many of our viewers and patients have these type of things or know someone who's had these type of things. And I want to take that mystery out of it. So maybe try to teach us a little bit.
Yeah, well, just to give you a general idea, brain tumors are exceedingly rare. They are so rare, in fact, that about 50% of the tumors that occur in the head are not even tumors primarily of the brain, but they are tumors of cancer that spread to the brain. Now, whether or not these need to be operated on, again, and I'll say this again because I've said it before, is we treat patients. Sometimes, depending upon the type of tumor, depending upon what is going on, the patient does not require surgery, requires radiation, in which case they will go see the radiation oncologist. In the circumstances of what are known, and you referred to as meningiomas, those are benign tumors, but if they are not removed, they can, just like a blood clot, but in a much more slowly progressive fashion, start critically pushing on the brain, causing weakness, causing paralysis, and potentially causing coma and even death. So in the circumstance of a meningioma, even though the tumor is considered benign, i.e. it will not spread like cancer, it still requires definitive treatment because without it, it will lead to the patient's worsening morbidity or worsening problems. So in the circumstance where we see a meningioma, if there are no symptoms from that meningioma, as you alluded to, somebody says they have a headache, you get an MRI, we see a very small, what is likely a meningioma. In the majority of those cases, a second MRI in 3 to 6 months and then another MRI a year or two may be all that's necessary. You can get meningiomas that essentially remain quiescent, that never grow. And if they're not causing a problem and they don't look like they're going to cause a problem, they are benign, they're not cancer, they're not going to spread, we don't need to do anything for them. It is when they start to cause problems, whether it's a meningioma, whether it's an actual tumor of the brain, something called a glioblastoma or an astrocytoma. Those things can either be treated with radiation or surgery, depending upon what they look like.
Tell us with malignant brain tumors, and we had a case recently, between us at the hospital, a young man, a middle-aged man, we'll say someone in late 40s who had this and really had a very difficult course.
Yeah.
Where have we come with regard to brain tumor treatment?
We still have a long way to go. There is active research when it comes to monoclonal antibodies, when it comes to a deployment of chemotherapeutic agents, different radiation protocols, the use of what are known as wafers, all kinds of very high technology things. But the unfortunate reality is a brain tumor, the ones that are actually in the substance of the brain do tend to be malignant, and in the overwhelming majority of them, even in young patients, they are not curable.
Tell us a little bit about pain. So we're going to switch topics.
Okay.
I know that you and one of your associates work very much with regard to pain treatment. Tell us a little bit what the role of a neurosurgeon is, even for something like trigeminal neuralgia, facial pain. Tell us a little bit where you come into them.
Sure. Well, trigeminal neuralgia is an interesting entity in that it is irritation of one of the cranial nerves, the trigeminal nerve. And without getting too detailed in the anatomy, it's actually a nerve that would kind of course. Can I borrow your pen?
Absolutely.
So it would kind of course right here at the base of the brain on both sides. This would go to the left side of the face, that would go to the right side of the face. And what research has shown just in the last 25 or 30 years is the overwhelming majority of those cases where there is trigeminal neuralgia, which is a very specific type of what is known as lancinating pain. It feels like a lightning bolt. It goes either down into the jaw or into the cheek. It's always on one side. It's generally worse when a person inhales with cold air. Sometimes eating can trigger it, but it is a very specific type of pain. Unfortunately, sometimes it's misdiagnosed as dental in origin, and you'll see people with trigeminal neuralgia come into your office. I'm sure you've seen this with 3 teeth pulled out because somebody kept thinking, oh, it's got to be the next tooth, and it's not. What it is it's a tortuous blood vessel that is pushing on that nerve, that trigeminal nerve, just in the right place, or you might imagine in the wrong place. And the pulsatility of that blood vessel is essentially causing misfiring of that trigeminal nerve, causing that pain. And what we do is we go in from the back, we drill a very small hole in the skull, and we put a little cushion between the blood vessel and between that nerve. And that essentially cures that person. And I can tell you that before this treatment was derived for trigeminal neuralgia, there was significant literature of patients with untreated trigeminal neuralgia that would commit suicide because the pain was so overwhelming and so incapacitating. And with this relatively straightforward procedure, we essentially remove it entirely.
I want to say thank you. What a quick half hour we had. I want to thank you so much for coming here and imparting all your wisdom of all the years of neurology and neurosurgery that we've been involved in. And I want to thank you. And I want to just have a direct thank you. Tonight happens to be my wedding anniversary. And I want to thank my wonderful, beautiful wife, Susan, and my kids, Harrison, Evan, and Jackie, for letting me out tonight to do this show. And thank you all, and happy anniversary, hon.
Mazel tov.